patients at the moment, but people with MS still need care, and it's working out the best way to do that. We've got people from the very top and the very bottom of the United Kingdom today. Starting at the top, we've got Rachel Morrison, who is an MS specialist nurse in the Western Isles, who is very experienced with remote working. Then from London, we've got Joela Mathews, who is a neurospecialist pharmacist who has some experience. And then down south in Cornwall, we've got Brendan McLean, who is, again, a very experienced neurologist in a relatively rural area as well. I'll pass on to my colleagues now and just let them say a wee bit about themselves, maybe starting in the very far north again with Rachel.
Hi there, I'm Rachel Morrison, and I'm an MS specialist nurse who covers the Western Isles of Scotland. So we have 9 islands that we cover with our health board. So it's quite a logistical kind of nightmare to get around all these patients at times. I've been in post for about 7 years, coming up 8 years now, and I'm looking forward to joining you today with the discussions around remote and rural working.
Now, if we pass over to Joela, if you can tell us a bit about your experiences of remote working.
So hi, I'm Joela Mathews. I'm neuropharmacist at Barts Health, and although not working remotely very often, because obviously we're living and working in central London, but our network covers a variety of trusts, so we use technology to undertake work across the network quite a lot by doing virtual MDTs, etc. So it's using technology just differently in these uncertain times, and making people feel at ease that they're able to do this. So NHS England are happy as long as, however you have an MDT, if it's virtually on the telephone, however, that's fine. So it's making sure that things are still safe for patients and we don't miss anything for them.
And going down to Cornwall, Brendan, can you give us a quick summary of your contact with remote working?
Hello, well, this is a very rural area, as Neil said. We've got a population of about 500,000, but it's a very long county. And the hospital services have been centralised, so patients have a long way to travel. As a result of that, we've been doing quite a lot of telephone clinics for quite some time, and we were involved in a pilot experiment some years ago with London. Because of the difficulties that we have in rural areas, and it's not just Cornwall, the whole of the southwest has got 2 big centres, but most of the population doesn't live in them. We're working to try and integrate network services, which will involve probably more remote clinics of the type that we're currently being sort of forced upon us. So this is a learning curve for us all on how to optimise the use of the remote video link, telephone link services for people with MS.
So thanks very much. I think based on the rough schedule that we'd got, if I could ask Rachel to just tell us a wee bit about her experience with running remote clinics, because she's been doing this for several years now quite effectively. Rachel, can you tell us a bit about what you do?
Yes, I can, yes. When I came into post 7 years ago, I was aware that we had to give an equitable service across the 9 islands that we covered, and I'd asked about using Skype, but was told that wasn't allowed to use that because it wasn't NHS secure. So we have a fantastic IT department and a tech team who I work very closely with, and they are brilliant and very innovative in how they help us deliver the care we need to deliver across the islands. So we started using a system called Attend Anywhere, which is it's basically the same as Near Me, and it's a video consulting service that enables people to have health and social care appointments from their home or wherever it is convenient for them to have them, be it a GP surgery or home or the local hospital in one of the islands. And all you need is a device for making video calls, like a smartphone and an internet connection. So we've had patients that are on fishing boats coming in and being able to have consultations from their fishing boats with their phones. So Near Me is a secure form of video consulting approved for use by the Scottish Government and NHS Scotland. And the benefits of using Near Me are that it's reduced a lot of their travel costs for patients to appointments, and it's much more convenient for them. It reduces the amount of time from work. We had one patient that was taking 3 days to go to Glasgow for an hour-long infusion appointment in Glasgow. So it's much more convenient in that respect. It's easier to attend if you usually take someone to your appointments, because as financial constraints on our health board, they're cut back on the amount of escorts patients can have, and the criteria for having an escort is really tight now. So at least if we can use VCs, patients still have the ability to have a loved one with them, or a friend or a companion that's able to kind of help them consolidate what's been spoken about in their consultation. It's better for the environment because we're not travelling such far distances. I mean, our main hub is in Glasgow, so for each patient that travels to Glasgow, it's nearly £400 return on the plane. So if you're taking an escort along with you, that's about £800 per consultation. And it also, in the climate we're in just now, reduces the spread of infectious diseases. All you have to do is to give your patient the website address, which they put into their browser, and most services will give you an appointment date and time as well. So I just give them the date and the time that they need to attend for their appointment. We have a generic sort of receptionist who will put them into the right clinic, and wait in a virtual waiting room to start their video call. They don't need to download an app or create an account or anything. It's very straightforward. They're taken through a check on their computer for their mic, their camera, and it's very, very easy to use. So for the patients to make the call, they just, as I said to you, they need a smartphone, a tablet, a computer, with a webcam and a speaker, which is usually built into the devices that they're using. A reliable internet connection is required, and we're fortunate that we have 4G now throughout the islands. And if you can watch a video online on your device, the connection should be good enough to have a video call. They usually use Chrome or Safari web browser, and basically having a well-lit environment to have the consultation in as well. And we have leaflets that we give out to patients, so they've got a step-by-step guide on how to use the video call and get the most from the consultation. We're very fortunate that we've been able to use this type of consultation for patients in their own homes, beaming into consultants on the mainland for rehabilitation, for advice regarding HSCT, and also because I want to be able to give an equitable service across the Western Isles, patients can beam in from their own homes if there is a problem. And I'm having to kind of work from home just now because of my own risks with regarding coronavirus. So it's not to change the service at all. I'm able to work from home and be able to kind of give the support to the patients that need it.
Thanks very much, Rachel. Now, we as a group actually went up and visited Stornoway a couple of years ago, which was a great experience just to see how things are up there. But the one thing that I also remember you talking about were some form of robots that you use in some situations. Yes. Robots might be the wrong word.
It's basically an iPad on wheels, which we've had in a patient's house to allow their loved ones or their carers to be able to beam in from their work, from their own homes if they're concerned about the individual. And it was really quite revolutionary. And also our IT department and tech team were really supportive in putting this device into this home for this patient who had increasing health issues, and it made it much more safer for her to be at home with her wee one as well. So it was really Right. I think you saw the beam when you were up, Neil.
I saw slides of it and possibly video footage. I don't think I saw the actual device itself.
Oh, right. Okay. Yeah.
It's just occurred to me that when we are actually looking at very disabled people self-isolating for a period of time, technology like that might have a more widespread application on the mainland as well. But that's just quite an interesting thing to hear about. Just to check, are there any questions at present for Rachel? Anything in the Q&A?
Not at the minute, no.
Okay, then perhaps if we move on now to Brendan. And Brendan, I was wanting to ask a bit about your experience of remote clinics and also what you do about examining patients under that sort of circumstance.
Thanks, Neil. My first experience doing remote clinics was actually with the Belfast group, who about 20 years ago, when they were faced with a shortage of neurologists and a large population they couldn't visit, set up what they described as remote video. What it needed at that stage, though, was they had to have a doctor or a medical person at the other end to do the examination for them. So they could do the consultation, the neurological consultation, and say, please tap the right knee jerk, and the right knee jerk got tapped remotely.
Brendan, sorry, we've lost you there completely. We might be able to bring you in on a landline, if we could do that. And there is a question for Rachel, Neil, if you want to do that. Brendan, for getting him on a landline.
The question for Rachel is, how did you initially set up your clinics? And did you send information out to patients asking them if this is something that they wanted to do? It's a colleague, Gillian Alexander in Moray, and she just really wants some advice on how to get things going, if that's something you could give us, Rachel.
An information day. It was an afternoon where we introduced the patients to attend anywhere, and one of the tech team came along and did kind of an example of, he was in another room and I was in the main room. So it was basically a way of showing the patient sort of live how we used Attend Anywhere. And also we have a leaflet that we could share with you if you wanted to have a look at the leaflet, which we send out to patients with a step-by-step guide on how to prepare for the actual consultation and how to get the most out of the consultation.
Thanks very much for that, Rachel. Brendan's back online now, but I don't know if he's going to try to phone in or if the IT problems have been solved.
Am I back on now?
You are, yes.
Yes, we're so remote down here. It takes a long time for the signal to trickle down. So when we set up our MS services, moving on, we were covering a large geographical area with one MS nurse, and it seemed really difficult to provide the service area that we wanted to just by face-to-face visits. There's two sections to this. We're constrained by the fact that when we have people on disease-modifying therapies, there's an obligation to see them and examine them once a year, because NHS England demands that for the continuation of prescriptions. So people have to travel for that, except in circumstances where that's not possible. And one of the things that we found very helpful was the fact that in clinical trial work, we were allowed to do remote assessments via telephone or video link for certain of the disability scores. So we thought that would be something that could work in the clinical setting as well. So sometimes we've used that when we don't need to do a hands-on examination, when you're doing people with more advanced disability in terms of walking distances. The nurses found it incredibly helpful to set up telephone clinics, and in fact, more than 50% of their work is telephone clinic work now, where they have got a fixed clinic list, and there's probably 4 or 5 a week telephone clinics being run for patients with MS, encompassing all the usual issues that might be dealt with in a face-to-face clinic. They still do run face-to-face clinics, but I think you achieve a great deal more by removing the stress of how do you travel, how do you park, how do you get into the right clinic space, are you going to meet the person you think you're going to meet? And so it's worked out that for some people, that has been a much better way of achieving continuity of contact and continuity of care. And people know they can phone in. And sometimes we are able to pick up people who have just phoned in with a problem and get back to them very quickly. The nurses also run quite a very active email advice service. So a lot of what they're doing is people emailing in, and then they will respond within 24 hours to provide an email response to questions and queries, which the patients really do find helpful. And we had a kind of survey done some years ago looking at patient acceptability of remote visiting, and it was much more positively received than we ever thought it would be. There's a little bit of a kind of old-fashioned traditional arrogance that you've got to be in the same room with the person for it to be satisfactory. And I think that's not the case. It can be quite challenging for people to express themselves in a limited time frame when you feel under pressure to get all your symptoms out in that 15-minute or 20-minute slot. And it's taken the pressure off people to do it that way. So we've found it's been a very effective way of dealing with people with a variety of issues and in a variety of circumstances. So I would think that this particular COVID crisis is going to make us all reassess how we use communication with patients. That there are those in whom a face-to-face is going to be needed for examination purposes when somebody feels that they might have had a deterioration and the only way to assess it is to see somebody. To those who don't need that sort of level of face-to-face contact and can have their assessments more remotely, be it by video link or by telephone or even email. As we found, Scotland's got a great advantage. Their health service until recently was always better than the English service. I have to confess, I was trained in Scotland, so I have a bias that way. But one of the things in England they failed to address is what's the safest method of doing video conferencing. And I think a lot of it is done in different fashions around the country. People are developing their own systems, and it would be very helpful that there was an agreed system that we all felt comfortable with and could integrate.
Thanks very much for that, Brendan. That was quite interesting. I mean, I've quite rapidly changed to doing 3 or 4 telephone clinics a week just in the past month. And today I had 3 new patients that I was talking to on the phone. And one gentleman actually had to ask him to get his partner to scratch the bottom of his feet and describe what the toes were doing. Yeah. Obviously, this is somebody that I would physically rather have seen, but the way our hospital is at the moment, we're not allowed to see people unless we absolutely have to. I'll bring him back as soon as things have calmed down a bit, but it's just a very different way of working.
Yes, and indeed it is. And I think you need to realise that there are certain times when you can act on not just your instinct, but the information given. And you can, for people who are in relapse, I don't think you need to examine to assess that somebody's in relapse. It's more for the nuances and subtleties of, is somebody changing, that we may see a change that the patient or family aren't aware of, where it becomes a bit more important. I agree.
In reality, in a yearly review, I like to check for spasticity and check the reflexes, and beyond that, it's all done by talking, you know, and if somebody else could do that without physically being in the room with me, it would be possible, you know. Okay, are there any questions for Brendan at this point?
Not at the moment, no.
Okay, now if we can move on to Joela, please. So Joela, we were wanting to ask you about the situation with home care and also a bit about the monitoring of all these drugs that we are using at the moment, because obviously some of our drugs do need monitored. So I'd welcome your thoughts on this.
So a lot of this is common sense. So I'll go through home care first. So 2 weeks ago, the home care companies were all speaking to NHS England, NHS Scotland, NHS Wales, all the home nations, and they were getting inundated by trusts around the country who wanted to change all treatments to home care, TPN, cancer treatment, even infusions. So obviously then there was a bit of panic about how they'll cope with the situation. Some of the home care companies then decided they would take no new MS patients for certain therapies, which then caused panic in the MS community, because we were like, what are we going to do with our patients who we're going to start on some of these treatments? Locally, your chief pharmacist will have assigned somebody the responsibility to go and help sort this out. And now other companies are taking on this work. So I know for our trust, we have been signed a home care company who will look after the new MS patients. So they shouldn't go without home care. So there is some work being done behind the background, and that work will have only got finalised last week. So it might be that that news hasn't filtered down to all the clinicians yet, that there's any delay. We weren't going to delay the starting of any patient on any medication. We were going to either just post it or courier it from London. And we had patients that had moved around the country, because London is a very transient population, who then decide, actually, I'll go back home for, well, instead of self-isolating in this tiny flat, I'll go back home. And therefore we were couriering medication around the country. Our outsourced pharmacy was only actually employing one courier, meaning if we were sending a courier up to, when I was sending one last week to Hartlepool, it meant that every patient in London didn't get deliveries of drugs that day. And this includes a range of conditions, including oncology and everything else. So it's being careful that couriers are actually then, we're not putting them at risk of traveling up the motorways on a motorbike. We're using the postal system, special delivery and posting medication much more than we used to, and asking for, and even though no signature is gained at the other way, you're able to track your medication that way. There are the issues that a lot of patients give a home care delivery address as their workplace, because that's where they are Monday to Friday, 9 till 5. So also reminding patients and checking with them, you're not going to be at your usual delivery address. Can we just check where we're delivering medication to? So there's some common sense elements. And also, like everywhere else, home care companies and community pharmacies and pharmacy in general have got the sickness levels. So everyone's working with these reduced capacity. So it's just a bit of recognition that everyone's doing what they can do. But there is work being done behind the background to make sure people aren't doing without medication. In terms of monitoring, it's use your common sense. So if you all know your patients and you all know what risks factors they have in their life in terms of COVID, in terms of their jobs, in terms of their living situations, and also in terms of the drug and what that's doing to their blood. So if someone has been stable for the last 5 years, been on medication, there's been no changes, you might reduce the monitoring schedule and just use your common sense. I know ABN is working on guidelines and they're getting updated really frequently. So you can keep an eye on there, but remember they are guidelines. They're not, these are the hard and fast rules of what we all must follow. And it's just using your common sense. There is also the big point of, if we do stop everyone's treatment and then delay everyone's treatment, when we come out of this at the other end, we're going to end up with a big mess of MS population who may be undertreated. So be careful at stopping medication to reduce the risk of COVID, because you might be just changing what the problem is. And in terms of remote prescribing, so I know a lot of the colleagues on the line might be working from home, and our trust rules for FP10s are, I couldn't give you an FP10 pad to take home and prescribe as you want. You would have to have some hands on the trust site to prescribe for you, but be careful of relying on individual people because they might go off sick. So I know that they're held centrally and any neurologist on site can access FP10s if needed to remotely prescribe. But because relying on primary care isn't always a great option as well, because GPs have the same problems we do.
Okay, thanks very much for that, Joela. Now, we do have a couple of questions that have come through. The first question, which I'll just read out, is commenting that it's easy for a doctor to make a consultation via phone, but what about IV infusion therapies? Certainly the patients that need to have IV infusion therapies in our unit are still coming to the unit. So our Tysabri patients are coming perhaps at a slightly reduced frequency, maybe every 6 or 8 weeks instead of every 4 weeks. Courses of alemtuzumab have been delayed at the moment, and courses of rituximab or ocrelizumab are being decided on a case-by-case basis, but infusions need to happen in a hospital site for us at present. Is that the experience that others have, or is it different in other parts of the country?
So I know in London there was work years ago looking at doing some home infusion service, and it never really took off because it was actually quite complicated. So patients had to sign up, which is fine, but you have to be in for your delivery of drug. You then have to be in for your infusion time, and then you have to be in for the collection of the sharp space. So actually there were 3 appointments you had to be in for, which in normal times was quite difficult. We have broached with NHS England that actually this could reduce the risk of patients who are currently staying at home, so they're in anyway, so staying in for 3 deliveries is fine, but actually could reduce the risk of these patients having infusions. So in the long term, depending on how long these weird circumstances last for, they are looking into home infusions and whether that's a possibility, with the caveat that obviously that takes nursing staff away from the NHS trust. So whichever company is delivering this, and even if they're being the nursing staff are being paid privately, it's still a nurse taken away from the NHS, however we look at it. And obviously that efficiency, they're not going to be able to infuse as much as they would in an infusion clinic setting. So it's just looking at the risk factors. And it's, if we got to the stage where the risks of going outside were so much higher, would we look into that? It might be an option for certain patients, but it will be looked at nationally rather than as per centre.
Rachel, what are you doing about infusions at present?
Well, we've relocated one back to Barra, and we have a GP and the cottage hospital dealing with that for us there. They've already been trained up prior to this in administering the Tysabri infusion, so they were quite happy to take this on because of those logistics of getting this patient to Glasgow during this time was really difficult, and obviously the GP there didn't want her going to Glasgow and coming, maybe bringing the COVID virus back to Barra, because they have no patients on that island at the moment with COVID-19.
Can I ask, Brendan, have you got any experience of home infusions, or how are you handling this at the current time?
We're not doing any of the MS DMTs as home infusions. We're doing it for other immunotherapies. We've also got the silly aisles off the end of us, and we've got some patients who are having other infusions done in the local GP practice. A lot of the concern that patients have is their risk of coming to hospital, and particularly if they're relying on public transport. That's raised a great deal of anxieties. I had one, in fact, an email this morning saying, it takes me 2 buses and a train to get to my Tysabri infusion. You know, how am I going to distance myself doing that? And that's a very tricky one to answer. We have managed, and I know it's not been easy in London, but we've managed to, our local private hospital has been effectively taken over by the NHS, and it's offering itself as an infusion unit. So we know we've now got a place where nobody who's going there is exposed to COVID as much as we can tell, or will be mixing with patients who have that risk. So that's given a lot of reassurance to the patients, but it's a temporary measure. And I think this sort of issue will be, should we be deferring infusions, and how long for? We are doing the same as you are. The only infusions that we're giving are Tysabri, and we've reduced those to between 6 and 8 weekly, just to avoid the exposure risk. That, if this crisis continues, these deferments we're doing will no longer be deferments. They'll be, how are we going to infuse people safely? And these options of home infusions will be an increasing issue for us to deal with. I know from some correspondence with colleagues in London, they're on the edge of coping with trying to deal with infusions because of the restricted access to the facilities they have. They share their infusion suites with cancer patients, etc., etc. So it's not been easy.
And I think that's a difficulty. The location often of your infusion suite. So we have moved our infusion suite from the main hospital into what was the dental hospital, which can't be turned into a COVID ward, which can't be turned into an inpatient setting. So therefore, it should be safe where it is. We have broached looking into private facilities as well, but in London, they are focusing on oncology patients because of the nature of oncology infusions. So we are competing with limited resource with a range of conditions. And I don't know if people saw the ONS stats today that the number of deaths not COVID related in the last week is 6,000 more than it is for a comparable week last year. So and that's taking away the COVID ones, meaning people aren't coming into hospital with other conditions. So it is worrying what we're setting ourselves up for without the COVID impact.
Thanks everybody for that. Now, there was a second part to that question as well, just asking about blood tests. Certainly we have reduced the frequency of blood tests. Some blood tests may be done in GP treatment rooms as opposed to people coming to the hospital for it. But we're trying to work out the safest way to do it. Some of the highest risk shielded patients may actually get their bloods done at home. But again, that's a big resource and it takes a MS nurse or a healthcare worker away from somewhere else, and you don't want to be taking the infection in. But we locally have a protocol for who really needs blood tests done and what blood tests can be postponed for a period of time. And again, that will adapt as the COVID situation adapts. Now, there's another question here asking, what do we do about MS relapses at the moment? I'll tell you what I'm doing or not doing at present, and then I'll open it up to the sort of field. We are assessing relapses over the phone. We are trying to exclude infection by bloods or urine, as we normally would. We're tending to advise against steroids at present because we don't want to increase people's risks or susceptibility to infection. I am asking for MRI scans if appropriate and necessary. I can't say that I'm always necessarily going to get them. And in terms of step-up treatments at the moment, Tysabri is the one that, for a variety of reasons, we are using if somebody has a dramatic worsening of their MS at the moment, because if they're JC negative or JC positive and it's for a brief period of time, it is probably relatively safe. But I'll pass that across to everyone else and just see if anyone else has comments to make on that issue.
Well, Neil, we're doing exactly the same as you are in England, and I was in fact on the advisory panel that tried to work out what we could do about blood monitoring, and it essentially is an evidence-free zone. But we followed what one of the statements made earlier. If somebody's been stable for quite some time, stable lymphocyte counts above 0.5, 0.8, depending on the drug you're dealing with, we are happy for the blood monitoring to be reduced to the minimum possible level wherever practicable. In terms of relapses, similarly, if somebody has a non-disabling relapse, we're trying to avoid giving steroids, and we're judging relapses by telephone. But if the relapse is somebody on Tysabri, I think the risk of it being a PML-driven one, if they're JC virus positive, means we're asking, and we're going to get MR scans. We've managed to persuade our MR department that they are urgent enough that they should be scanned. If you're fairly convinced it's a relapse in its own right, it's more down to the capacity of the MR department as to whether they'll agree to do it. But we are asking them, and they're by and large, they're being very helpful. Obviously, they've had to ration their scanning because of their own staffing issues. It's not so much scanning time as availability of technicians who are going down with COVID. I think that was covering what we did. Yep, and Tysabri, I agree, at the moment looks to be the safest of the escalating therapies, as far as we're aware, given that theoretically, as it doesn't deplete lymphocytes, it should be a safe one to consider in a for short or medium term in patients who are breaking through.
Rachel, do you have any comments to add about what you're doing for relapses?
Just exactly the same as yourself there, giving the patient the option of, if it is a disabling relapse, to have the steroids or not, and making them aware of the risk, increased risk of having the steroids, and basically just doing exactly what you're doing there. Yeah.
Okay. Now, we've got another question in the Q&A section, and it's asking about the use of self-monitoring batteries like a timed 25-foot walk and questionnaires for quality of life and everyday living in a remote service. Does anyone have experience of using these sort of self-assessment batteries in your services? Brendan or Rachel?
Well, we do them in the research field because we're locked down in terms of doing their clinical research, and with our MS trials that are involving these assessments, we've got, in one of the trials anyway, the capacity to do it by telephone. So in fact, we're doing that now for the clinical trials. In clinical practice, we've not extended it to the clinical patients. I think we're all sitting waiting to see how long this lockdown is going to last for before we then say, right, maybe we need to start embarking on using these remote monitoring tools, quality of life assessments, etc., etc. We're going to have to think about it, I would think.
Rachel, do you want to add anything to that, or?
I usually used to do these face-to-face, but like Brendan has said there, I think if this goes on for much longer, we may have to look at sort of doing it by VC or telephone and emailing the forms. I use the AIMS assessment tool that Glasgow use.
Yeah.
So you could email these forms on to the patient and get.
Rachel, nobody else will know what the AIMS assessment tool is, so can you describe that?
It's obviously the same. It's very similar to what's used in research purposes, isn't it, Neil? I think. Yeah.
Well, it's meant to actually be a clinical monitoring tool because it's been done by an NHS service, not for research reasons. It's meant to, I think, give a baseline for assessing progression.
I usually do it on an annual basis, so you can see if things have stayed the same, improved, or progressed in any way. And there are a barrage of different questionnaires that patients fill out on an annual basis, or if they're worsening symptoms.
Okay. What does that involve then? Is it a timed 25-foot walk?
Yes, there is. There's bladder and bowel assessment. There's a timed walk. There's a quality of life measurement. There's a fatigue index score. I think that's the main 5, is it, Neil? I think.
Okay. Thanks very much. That is used in Glasgow. It's not used in Lanarkshire yet, although we were working on rolling that out prior to all of this, and it will eventually happen because we need to be able to measure progression, which we really don't do very well. Okay, I've got another question here. It's just really asking about the treatment of relapses, asking if it's acceptable to use oral methylprednisolone instead of IV methylprednisolone. Certainly, I would quite routinely use oral methylprednisolone for somebody who's having a relapse unless they absolutely had to be in hospital. Just at present, when there is a viral pandemic going around, I would avoid high doses of steroids generally, if at all possible, because we don't want to impair anyone's immune response just in case they catch COVID. Joela or Brendan, would you say anything different regarding that?
No, that makes sense, but it would be on an individual basis, because some patients, even the COVID's around, are actually low risk because of their own personal living circumstances and being able to isolate very well.
Okay, cool. Now, there's another question here. If a treatment has been picked before COVID, but the patient is not currently on treatment, what treatment do you prefer to start? If a patient has highly active MS, which treatment is better at present, or are you delaying? I'll answer that for myself at the moment. Currently, for new patients just starting treatment, we, for a variety of home care reasons, are only able to access either dimethyl fumarate or Tysabri for, just starting. I had one patient who really wanted Avonex because they want to get pregnant soon, so we were able to give them Avonex under special circumstances, but we are slightly limited as to what is easily available right now and felt to be safe. So somebody's got bad MS right now, they're getting Tysabri and they might change to something else later on. If somebody's got, I'm not going to call it good MS, but less severe MS, they're getting dimethyl fumarate if they can tolerate that. And that's just looking at monitoring needs as well as what we're actually able to get delivered to the patient at present. What is the experience across the rest of the country? Are other people doing things differently?
So we're doing the same as you. We have access to all of the medication, but actually in reality, people are only starting on dimethyl fumarate and natalizumab.
Yeah, and I'd add to that, I think it's down to what's the safest thing to give from the healthcare professionals' viewpoint as well. We would start aggressive MS on natalizumab with, as you would phrase it, not so aggressive MS. The choice is limited because of the training required, and we don't have the capacity at the moment to train people up to self-inject if they were suitable. So we're trying to use the option that's the least invasive for both healthcare professionals and the patients, and it would be oral agents.
Thanks very much. Rachel, are you actually able to get all the drugs on the island at the moment?
They're being couriered over or posted over, I think. That's what's happening through home care. I've just had a patient, a newly diagnosed patient last week that's going on to treatment, and it's BMF they're going on to. Yeah.
Okay. That's great, thanks. Now I've got another question that's come through. Given the COVID situation, what are our thoughts in terms of conducting video consultations like this meeting? I think I'll answer that myself first. I think it's something that we're going to be doing in due course. I probably won't be doing it from my spare room if possible. I'd probably prefer to do it in a clinic room. I will try and dress smartly if I'm doing a video consultation, whereas I don't need to do that quite as much if I'm doing a telephone consultation. It's going to be a way of working that we're going to need to adapt to. But how does everybody else feel about video consultations? I get the feeling that people are relatively happy with them.
I think they're okay, but it's also being careful that you're using something that people are happy in your information governance and your IT department. So you're not doing it on your personal phone, it's compliant. The NHS Digital have relaxed the rules currently in terms of information governance. So although some of this is great and we will want to carry on some of this post-COVID, the rules might come back into play, stopping some of it. So I know that our trust was trying to broach Skype for Business as the tool of choice, which a year ago they said, oh, it will take 5 years to bring in. It's now come in quite quickly for a range of specialities.
Okay. Rachel or Brendan, any comments?
I think, as with probably Rachel, I think if patients find that their visits to hospital or visits for any other investigations, bloods, etc., can be mitigated, you know, a 3-day round trip to an hour's consultation is not a great advertisement for a service. And so I think there will be very reasonable instances where we will increase the use of video consultations. And there's something nice about seeing somebody as well. We will probably increase the use of these in circumstances where travel is too much or too onerous. I still think you need some aspects of face-to-face, because telephone consultations are all very well, but people get psychologically, both sides psychologically benefit from seeing people. And we know that gives people an emotional boost if they think somebody's seeing them and they can see them. So I don't think telephone consultations will take over completely, but I think the video link has got the security side of it to sort out. I'd be very happy doing them, as well as, in fact, have all three: telephone, video and face-to-face, depending on need.
I think it does increase the efficiency of a service if we're able to access these appropriately. At the moment, we're being forced down one route, so it feels unnatural. I think that will change as we all get used to it, and we're all better ourselves at using the technology.
Mm-hmm. I'm agreeing with Brendan there about allowing us to deliver a much more comprehensive service to the patients. When you look, we're now linking with a rehab consultant in Inverness, who, yes, comes over twice a year, and patients have the opportunity to be seen face to face. But if we have any issues in between times, we can VC from the patient's home, and she's able to kind of advise with positioning and specificity and all sorts of different things with us. So it's having the mixture of them all together, I think, are really important.
Okay, thanks very much. Now we have another question coming through the Q&A section. For a newly diagnosed patient with a non-aggressive RRMS, what treatment do you recommend as a starting treatment now, and who would help the patient for the first administration? Now, again, you always will have a shared decision with the patient as to whether or not treatment should be started. Not every patient with relapsing remitting MS necessarily will want a treatment or necessarily will benefit from a treatment, depending on individual factors. But normally I would offer either dimethyl fumarate, teriflunomide, or an injectable to people with non-aggressive MS who merited treatment, and let the person choose what fitted their lifestyle plans. As we'd alluded to earlier, right now the only drug that I'm really able to give people is dimethyl fumarate. Hopefully we'll get more options again in due course. And in terms of assisting somebody with the first administration of dimethyl fumarate, apart from some instructions on how to take the tablet, ideally with food, I don't know that there's really much else that you would need to do to assist somebody in that circumstance. Training up to give an injection is a wee bit harder. I understand that there are some videos on YouTube for the sort of brave people out there. I've certainly seen similar self-administration needle videos in the past, and I can figure out how to do it, but I'm a healthcare professional. So most people, I think, can follow an instructional video if need be. Do any other people have thoughts on starting treatment in non-aggressive MS at the moment and what you would do? Maybe Brendan first.
Yes, no, I'm with you on this one. It's getting access when the service is stretched to somebody being prepared to train you. And I think the online videos, it's not quite the same as having somebody with you and demonstrating things. I think it takes a brave person to initiate, a potential long-term treatment on their own. I would go with you and say that probably the safest agent is giving DMF There's nothing particularly difficult about, you don't just show somebody a video on how to swallow a tablet. So hopefully that's, and remember, these things can be temporary measures. We're trying to get somebody on treatment, which can be altered in the future if it proves to be not the ideal choice for that individual's either MS or their lifestyle choice. So these are just ways of getting us through this crisis at the moment. And options can be changed in the future if necessary.
Okay. Joela, do you have any comments to add on that?
And just a reminder that if you did want to start someone on an injectable, and yes, you have the videos, you may be able to ask for a dummy pen from the manufacturers, from the home care company, to aid the training of someone over the phone or putting it into an orange, because obviously you don't want to inject the actual injectable everywhere, but you might be able to get a dummy pen for them, because obviously they want to aid that as well.
Okay. Now we are at 5 minutes to 6, so we're very nearly finished. We don't have any active questions in the Q&A section. Looking down the chat section, most of the questions have been covered. There was a question about the lymphocyte count being lower than 0.8 on treatment with dimethyl fumarate. 0.8 is probably safe. 0.5, when you get a full blood count and you don't get lymphocyte subsets, you could quite easily have a patient who's got a CD4 count of 200 and not necessarily know about it. So 0.8 I'm happy with. I start getting twitchy if it goes to 0.6. Again, we do see a certain proportion of people with dimethyl fumarate whose lymphocyte counts drop and stay low for over a year, so it is something to worry about. In some ways, I would worry about a low lymphocyte count on dimethyl fumarate more than I would worry about a low lymphocyte count on cladribine, but that might be a slightly controversial opinion. Does anyone else have other thoughts regarding lymphopenia with dimethyl fumarate?
It's also looking at the trend rather than the absolute number. So if someone's running at 0.8 but has been doing for ages, no problems, and I'm not worrying. It's if they usually run high and this is the trend is going down, then I would want to ensure that they have the next blood test and we don't delay that monitoring.
Yeah, I would agree. That's the crucial thing, is the trend. If somebody has had stable lymphocyte counts at 0.6, for example, for a year and have not got into trouble, I wouldn't be getting too worried about that. And as you say, we don't do the subsets, and that's probably a problem we're going to have to face anyway. It's very difficult to get the subsets done, but it's the trend that I think is more important.
Okay, well, we are now at 1 minute to 6, and we've managed to avoid using any of the slightly scary questions that Professor Giovanni sent us earlier on. So I think we're safe. Thank you very much to all the members of the panel, and thank you to the participants who have logged on to listen to this. I believe there will be a properly edited version of this that appears online for you to review at your leisure in the future. Okay, so thanks again, everybody, and I think we'll sort of wind it up officially later, okay?
Thank you very much, everybody.